Hello, everyone, and welcome to our webinar today. This is Cody Sipe with the Functional Aging Institute. So glad you guys are here with us, and what better time to sit in front of a computer and learn more about your craft. I think this is probably a good time to do that, probably more than any other time you've had or we've had. So really excited that you guys are with us today. Just a few note-keeping things before we get started. If you want to send in some questions, you can send them in via the little chat box, and we will try to get to those a little bit later on, probably closer to the end of the webinar, when we'll try to answer some questions. And this is being recorded, so we'll also make this available at a later time as well. So excited to once again have Dr. Emily Splichal here with us. Emily, so glad that you're here.
Thank you so much. As always, it's an honor to be invited to do a webinar for Functional Aging Institute.
Wow, thank you so much. If you guys don't know about Emily, you really need to follow what she's doing. She has some just great information on kind of foot to core sequencing and barefoot training, and a lot of great topics that are very ideal for the middle-aged and older adult populations that most of us work with. Her background is in podiatry, and you're based in New York City still, correct?
I am, yes.
Yeah, so busy New York City. But also as an exercise expert, and really the combination of those two areas of expertise is pretty unique, wouldn't you say, Emily? Not too many people
Yeah,
with that combo.
probably the only person with that combination, or one of a handful.
I would say so. Yeah, very interesting. But Emily spends a lot of time teaching in lots of different ways. She's very giving with the expertise that she has, and teaches all over the world. So very excited that we can have her once again with us today. Always a very popular presenter here for us at FAI. So Emily, I'm just going to turn it over to you and let you get started on your topic today.
Okay, sounds awesome. Thank you so much. And to follow off of what Cody had said, I really appreciate you taking this time during the current state of affairs to focus on yourself, to grow your knowledge base. I find that, during periods of situations of matters that you cannot control, what you can control is your self-growth, and your education is something that is always an aspect that should be focused on and grown upon. So when Cody and Dan invited me to do a topic, I'm very appreciative of every invitation that I get. I wanted to do one that was perhaps a different spin on feet. I do speak a lot on foot to core, a lot on barefoot science, but I do want to focus on the changes that are happening with a lot of your clients' feet that is potentially making it difficult for them to do certain exercises that you might recommend for them, or really just overall movement patterns. It might help you to understand some of their compensations, as well as maybe some of their injury patterns. Cody did a great introduction of me, my background. If you do want to learn more about our education, please go to ebfaglobal.com. We have many webinars on our YouTube channel. So if you have some more free time over the next several weeks to a month and you want to check out those lectures, then please do so. I will also be mentioning Noboso towards the end. I'm the founder of Noboso Technology, and really a huge advocate of building an awareness of movement longevity and how we can use sensory science to optimize human movement patterns in our clients. Now, my goal through the next, let's say 45 minutes to an hour, is to build this appreciation towards movement longevity and around anti-aging movement or functional aging, movement longevity, all of these aspects, super, super important. But we want to understand the reality of the changes that occur in our client's body. I'm going to focus on feet and how that often interferes or could create barriers to the exercises and the programming that you develop for them. These are going to be the 5 aspects that we focus on with the aging foot. We're going to be looking at joint mobility changes, how that affects movement patterns, and of course the exercise programming that you give, muscle strength changes, fascial and collagen changes, peripheral nerve changes, and then skin and vascular changes. The first one that we're going to focus on is joint mobility changes that are occurring in the foot and the ankle. Now, if you're thinking of osteoarthritis in general, this is affecting more than 54 million adults in the United States. Osteoarthritis is the most common type. If you think of osteoarthritis versus rheumatoid arthritis, RA is more of an inflammatory arthritis, where OA, also known as degenerative joint disease, is typically I'm quoting here, quote, non-inflammatory arthritis. Doesn't mean that client doesn't experience inflammation in the joint when they stress it, but it's just classically a little bit different presented than RA, which is an autoimmune disorder. So when you're thinking of degenerative joint disease, osteoarthritis, a majority of our clients and individuals over age 65 have some degree of OA. Now, is it in their hip? Is it in their shoulder? Is it in their knee? Or is it in their foot? We are going to be focusing in the foot and the prevalence of osteoarthritis that we're seeing in the foot and the ankle. Now, these are the main joints that you want to be thinking about that could be impacted by osteoarthritis and degeneration. The ankle joint. Ankle arthritis is extremely painful for a client. And you want to understand and appreciate how you can modify either their footwear or their exercises to take some of that stress off of the ankle joint. Subtalar joint is another very common one. We see that one in flat feet a lot, midfoot or the talonavicular joint, if you're familiar with that joint. And then, of course, we do have to mention the first MPJ or the great toe joint. So these are going to be the most common areas that are going to be affected by osteoarthritis. I would say 2 of the most common that you would see of these are going to be the great toe, the first MPJ, and then the ankle. Now, one of the biggest contributors just across the board with all of these different arthritides that we see in the foot is flat feet. So if you have an older client that's coming in and they have flat feet, the chance of them having osteoarthritis within those joints is going to be higher. This is why I'm such a huge advocate of strengthening the feet earlier. So in your younger clients, before they get to this point, prevention is always the best medicine versus being reactive in your approach. So if you think foot strengthening, keep the feet strong, make sure you use proper footwear, strengthen the glutes, strengthen the core. These are all ways that you can help your clients as they transition through these different phases in life to avoid some of these arthritides or degeneration in the foot and the ankle. Because again, if your ankle's not moving, your subtalar joint's not moving, your midfoot, your great toe, you cannot walk the right way or properly or optimally. This means that every step that client takes, they're going to be compensating. One of the most classic changes in gait that happens with arthritis in the foot is that the client becomes what's called apropulsive. So that means they're no longer releasing energy efficiently through the fascial connective tissue. Instead, they become more like they shuffle with their gait or they march. So they have different gait patterns. As soon as you start marching or you shuffle, that just feeds compensation patterns and it feeds restrictions elsewhere in the body. And this is where people start to become, their whole global system is extremely painful. As soon as they wake up out of bed, they just have chronic pain all over their body from a osteoarthritis perspective. So think of what can you do for your clients to control that flat foot before it gets to osteoarthritis of the ankle and the midfoot and the great toe. As soon as it becomes ankle, midfoot, subtalar, great toe, biggest thing when it comes to osteoarthritis is that it starts to become structural changes. So if you can see in this x-ray, this is an x-ray of ankle arthritis. When you look at a joint that is degenerated, whatever joint in the body it is, you're thinking of a joint that has lost its joint space. So if you were taking notes and kind of thinking how you can process this, is a joint that is arthritic is tight. It's almost collapsed on itself. It's lost the cushion of the cartilage and the space of the joint fluid or the hyaluronic acid that is within the joint and creates that cushion, like a synovial fluid is really what it is. So they are bone on a bone. As soon as you start getting bone on bone, this is very painful to the client. And what their body does is it doesn't want to move through pain. So it starts to restrict that pain. This is where you start to hear of spurs. So spurs are developed when the client is moving on a arthritic joint. It's painful. The body wants to stop that movement. So it creates spurs to lock down the joint. That's essentially what's happening. Yes. Now, because there's so many joints in the foot, there's 33 joints in the foot, 20 of them are actually actively articulating. These are many different opportunities for osteoarthritis to form. So this is why OA in the foot is something that is definitely prevalent with age. I see many patients that are over age 65 with osteoarthritis in their entire midfoot. So think of all the small joints that are on the top of the foot being very painful. So how can we help these clients? How can we keep them moving, but then control their pain? Using footwear, such as this is an example of an MBT, if you're familiar with the shoe company. MBT is a rocker shoe. It's one of the first rocker shoes that's on the market. Some of the other rocker shoes that are more mainstream are Skechers. Skechers got a bad reputation from it, but I am a big fan of rocker-based shoes. Now, if you look at the shoe for just a moment, I want you to appreciate that there's a rocker on the front of the foot and there's a rocker in the back of the foot. So the back of the heel rocker, so that's a heel rocker, is beneficial for ankle arthritis. So if you have a client that has ankle arthritis or severe ankle pain, then you want to look at a heel rocker, a shoe with a heel rocker. Skechers Shape Up has it and MBT has it. Now, if they have more arthritis in the big toe, the first MPJ, then you would be looking at more like a 4-foot rocker, which this has as well. This has a combination. Some other brands that have 4-foot rockers, Dansko is a really good brand. I recommend that a lot to my patients. Hoka, so if you're familiar with Hoka 1-1, so the ultra marathon shoe, it does have a rocker in the 4-foot. And then another good one is Reshod. So reshod.com. Is another brand that I like. It was actually developed by a speed walker. So they appreciate the 4-foot rocker with speed walking. Those are my top recommendations for clients or for patients. Heel rocker, ankle arthritis, 4-foot rocker if you start to have great toe first MPJ. Now, if you have arthritis in, let's say, your subtalar joint or your midfoot, again, the whole goal when you have arthritis, especially severe arthritis, is you're not trying to bring mobility to these joints. You want to be really, really careful about trying to create a very mobile foot when the entire foot does not have cartilage. It makes it extremely painful for these clients, and they're not going to be able to want to move. Yes, I understand that foot mobility is important, but you want to understand the appropriateness of that. Okay, so if you have subtalar joint midfoot arthritis, this is the brace that I recommend. You can 100% have your client use this brace and do their exercises. This is typically used in conjunction with orthotics and things like that. If you have a client that has severe foot and ankle arthritis, a lot of podiatrists will recommend what's called an Arizona brace or a Ritchie brace. They're really big and bulky and made of plastic and leather. The compliancy rate of clients or patients to use those braces is very low. So I actually don't recommend them. I recommend this ASO that you can buy on Amazon. I think it's $25 on Amazon. It laces up. It is great. Do not get any other brand except ASO. Go-to brace for rear foot, midfoot arthritis. And then they start doing their exercises with you, and this is going to control their pain immensely. Now, if your client does not have severe or painful arthritis, you want to focus on keeping the feet strong to avoid the formation of arthritis. This is where we go to short foot. I've done short foot many, many times in so many webinars that I've done for FAI and through EBFA. So please do check out more information on the EBFA website for how to do short foot, how to integrate it into your exercises. You're essentially keeping their feet strong, them barefoot strong, keep the sensory information coming in so that we can avoid these arthritic changes in the foot. Now, our second topic of age foot changes is muscle strength changes. Now, muscle atrophy and sarcopenia, so the estimates do range quite a bit depending on your definition of sarcopenia, but you're looking at approximately 10 to 40% of adults over age 65 are going to experience some degree of muscle atrophy, muscle weakness, muscle denervation. They're just part of the age-related changes. Now, what is that potentially contributing to gait changes, to foot changes, foot strength changes? Since we have more than 100 muscles in each foot, we want to be thinking of this potential impact of muscle atrophy. So not only are your clients' quads, biceps, glutes atrophying or potentially starting to get some sarcopenia, but so is your foot. And the foot is so important for gait, balance, and mobility. So we want to also understand what is happening in the foot from a muscle change perspective. Now, there's two types of muscles in the feet. We have intrinsics, which are the small muscles in the bottom of the feet. They originate and insert in the bottom of the foot. And then we have extrinsics, which are larger muscles. These originate in the lower leg and they insert in the foot as tendons. Both of them are going to experience atrophy and weakening with age. But if we focus on the intrinsic muscles first, these are the small muscles. The primary purpose of your intrinsic muscles is to, one, help to absorb shock or impact forces. Every time your foot hits the ground, these small muscles in the bottom of the foot contract and they stiffen to absorb the impact forces. I'm going to talk more about that in a little bit. Another action of the intrinsic muscles is that when they contract, they stabilize your MPJs, which is the lever of the foot. This means they essentially are stabilizing the digits. So one of the biggest changes that happens when you start to get intrinsic muscle atrophy and weakness is that your client is going to start getting hammertoes. You can see in the picture here to the left, I know that might not be an overly attractive picture to you. However, that's the reality of what a lot of older people's feet look like, with the onychomycosis or the fungal nails included. So the contractures that you see here, so I don't even have to touch this foot to know that this client has rigid hammertoes. They have an atrophy and a weakening of the intrinsic muscles in their feet. When these hammertoes start to become rigid, not flexible, but rigid, that places higher forces into the ball of the foot. Later, we're going to speak about fat pad atrophy, and this greatly contributes to the stress that's placed on an older client's ball of the foot. So if your client is complaining of ball of foot pain, if they have hammertoes and they have intrinsic muscle weakness, that's going to start making sense. So what can you do for the client that's starting to get intrinsic muscle weakness and is starting to get those contractures that are happening? One, please determine if it's rigid or flexible. Take the toe and try to pull it straight. If you look at this picture here, if I were to try to straighten this woman's or gentleman's toes straight, those toes are not going anywhere, right? So that would be classified as a rigid hammer toe. If you have a client's toe and you can pull it straight, but as soon as you let go, it contracts again, that would be a flexible hammer toe. That is one that we can turn to products such as correct toes. If you try to use correct toes with a rigid hammer toe, you still can. And I tell my patients who are over 65 and have feet very similar to the prior slide and say, I'm recommending you use correct toes just to keep the flexibility and kind of space between the digits. not with the understanding that those toes are going to miraculously go straight. That's not realistic. It's not happening. The only thing that's going to make rigid hammer toes straight is surgery. If they're flexible, absolutely, you could potentially help them to become straight. But what I do want to emphasize is still creating that space. When you start to get hammer toes like this, all of the knuckle of those toes start to hit each other. You get these corns in between the toes. Super, super painful for your clients if they start to get hammer toes and they're bumping up into each other, especially in the shoes, and they start to get these interdigital corns. Very painful. So please look at correct toes, stretching, getting some space in between those digits, strengthening those intrinsic muscles. My go-to short foot is strengthening those intrinsic muscles. Now, muscle strength, specifically isometrically, is used to damp impact forces. I mentioned this a little bit earlier. This is where I had said that intrinsic muscles have a role in absorbing impact forces. So what happens is they contract isometrically before your foot hits the ground, creates stiffness in the foot, and almost like a splint along each of these long bones in the foot, which is called a metatarsal. And then that splint protects the long bone and helps to avoid stress fractures or fractures. So the weaker that the muscles in the feet become, your client actually has a higher fracture risk. Stress fracture, or technically if they keep pushing on a stress fracture, it could be a legit fracture. You have someone who also has osteoporosis or osteopenia, and you combine that with intrinsic foot weakness, and you have for sure a fracture risk in your client. If you have a client who is a fall risk in general, and then you add the fact that they just got a stress fracture because of what I just explained, and now they're in a surgical boot or a cam walker, that greatly contributes to fracture or to fall risk in seniors. So you really want to be focusing on how can you keep the feet in your clients strong so that they never get a stress fracture, so they never have to go into one of those fracture boots, so then they never have to get into that susceptible situation where they could potentially get a fall and then they fall and then they fracture their hip or something like that, right? We want to be as proactive as we can. Now, from an extrinsic muscle perspective, one of the extrinsic larger muscle changes that you see with age happens most commonly in the posterior tibial tendon. Now, your posterior tibial tendon, when you start to weaken this muscle, it's referred to as PTTD, post-tib tendon dysfunction. So when you start to get post-tib tendon dysfunction, this is one of the most common causes of adults acquired flat foot. So if you see suddenly that one of your clients' arches falls, one side, one foot falls, that's a classic posterior tibial tendon issue. Now, why the post-tib tendon is so important is this muscle is the primary stabilizer of the foot, primary dynamic stabilizer of the foot. It's the muscle that is very important for pulling your foot into what's called a lever position. So if you were to do like a heel raise or you're about to take a step and your foot is in that plantar flex position, that's called a lever. So that lever is really controlled by your post-tib tendon. If you can't get into that position, you cannot walk the right way, you cannot walk efficiently, and this is what's going to contribute into movement imbalances you see in the older client. Now, again, post-tib tendon dysfunction being the number one contributors to flat feet, makes them susceptible to osteoarthritis. So everything that I had said earlier, as far as trying to avoid flat feet because of arthritis, this is where you would want to look at that. So if you have a client that has post-tib tendon dysfunction, let's say on their right foot here in this picture, that right side is going to be more susceptible to ankle arthritis, subtalar arthritis, midfoot arthritis, bunions, and into a first MPJ arthritis. So you can see that all of these things start to become very much interconnected and related. Now, the number one test to gauge the strength of that tendon or that muscle in your clients is to do a single heel raise. So if that is a big takeaway and you're trying to gauge baseline strength in your clients, do a single heel raise. If your client cannot do a single heel raise, a single calf raise, right? Not bilateral, they have to stand on one foot and lift their heel. If they cannot do that, or you're not training that skill in them, that is dramatically impacting their gait, their walking pattern, which means they will not have the strength to take a proper step. So what do? They shuffle or they march. One of the next changes that we see with age are fascial and collagen changes. Now, when you're thinking of fascia and collagen, what I want you to think that comes to mind right away is mobility. Your fascial, your connective tissue, your fascia surrounding every muscle fiber in your body. So mobility issues with age are fascial issues. Fascial issues are collagen issues. So you want to ask yourself, what are the changes that are happening to the collagen in my clients with age? This is what's happening. We're starting to get non-enzymatic crosslinks. So you start to get these different crosslinks, which are sticky points between the fibers that's occurring because of glucose, elevated glucose. You, of course, see this at a greater prevalence with diabetes, but it's not just diabetes because there's an age-related change in glucose sensitivity with age. So your ability to manage your blood sugar even without a diabetes diagnosis starts to get affected with age. Now, if you want to stay within fascia within your entire body, you can, or if you want to stay specific to the foot, we can think about your plantar fascia. So with age, the plantar fascia elasticity starts to change. It starts to become less elastic. So in many of your clients over age 65, you want to start thinking they're getting plantar fascial changes. It's becoming stickier, it's becoming thicker, it's less like a rubber band, which means that every step that they take, they're going to potentially stress the insertion of that plantar fascia. And that stress to the plantar fascia is going to start creating micro tears. And those micro tears can start to create inflammation and then stickiness, and it becomes plantar fasciosis. And then you start to get plantar fascial tears that occur with an increased prevalence with age. Now, what's important about your plantar fascia is that it's like a rubber band with every step you take, and it's related to arch compression. So you need to be able to have this elasticity. So now if you're thinking of how do I avoid plantar fascial issues in my clients, or just general mobility issues in my clients, please remember that it's a collagen issue. It's a crosslink issue, and it's a stickiness within that tissue. This is why, or I emphasize that, because you want to address it really not through stretching. You want to address it more through trigger point release, SMR, Graston, dry needling, acupuncture. So you want to address it with the advances in fascial research that are out there versus thinking more static stretching. And this is in general, but particularly for the older client that has stickier, more dehydrated, less rubber bandy tissue, you really want to appreciate these advanced fascial techniques for them. I believe that every client over age 65 should have a very structured SMR routine for their mobility and make sure that they're getting into the areas of highest cross-linking for that individual. If they're sedentary, it's going to be in the hips, obviously. We want to be thinking about the feet, specifically the plantar fascia. I tell every single one of my patients, whether they're 65 or 5, it doesn't matter, that they should be rolling or standing on a lacrosse ball or a golf ball on the bottom of their feet 5 minutes every day if they can. Doing small doses of addressing the fascial restrictions goes much further than 10 minutes twice a week. Now, the next area that we want to focus on, as far as changes that are happening within the aging foot, are, of course, peripheral nerve changes. Anyone who follows any of my work knows that I'm very much into the sensory system, into the peripheral nerves, and how we can optimize this part of the body and movement patterns to improve movement longevity. So of course we're focusing on peripheral nerves, so we're going to be talking about peripheral neuropathy and the changes that are happening in the nerves that innervate the feet. Now, if we look at just some of the statistics, if you're thinking, how many of my clients over age 65 might have peripheral neuropathy? Maybe you're not asking them. I really hope that you are. But this is the prevalence of what we're seeing from a numbers perspective. Diabetes neuropathy and chemo-induced peripheral neuropathy are the two most common neuropathies really in the world that we're dealing with. Other ones are going to be nutritional and idiopathic and things like that. But you just want to think of diabetes and chemo-induced. Now, if we look at diabetes and the diabetes rate, 34 million adults are living with diabetes. Half of those will have diabetic peripheral neuropathy, which is ridiculous. Those who have diabetic peripheral neuropathy are at a 15 times greater fall risk, which means that any client that's coming to you with the earliest signs of peripheral nerve changes, we of course need to be doing fall reduction training and foot core sequencing and strengthening those feet. If we look at cancer statistics, there's 1.76 million new cases of cancer every year in the United States. 60% of those are undergoing chemotherapy and will experience, 60% of those experiencing chemotherapy will get neuropathy. So a chemotherapy-induced peripheral neuropathy. Now, if you look at chemoneuropathy, a lot of neurologists, or a lot of oncologists, my apologies, a lot of oncologists will say, yeah, don't worry about it. It'll reverse. A lot of chemo-induced peripheral neuropathy actually does not reverse. And it's unfortunate. The oncologist's priority is addressing, obviously, the cancer. So it takes a lower priority. And then the patient as well, from a priority schedule, just wants to address the cancer, and then they'll deal with the neuropathy towards the end. And then that's kind of a constant reminder of what they went through. So we just want to make sure that we're appreciating that. If we think of the last case, 1 million people in the United States are living with multiple sclerosis. 1/4 of those people with MS will experience neuropathy and typically a foot drop as well. So these are quite profound, the amount of peripheral neuropathy that we will see in our clients over age 65. Now, I happen to have done a 1-hour webinar with FAI on peripheral neuropathy. So please do check that out. I'm sure that it's housed on the FAI site somewhere, or you can head to the EBFA YouTube channel and listen to 60 minutes of nothing but neuropathy, different types. What are some of the causes of it? How do you treat it? How do you address it from a movement specialist perspective? So please do check that out, youtube.com/EBFA fitness. But what we can say from the get-go is, if you have a client with peripheral neuropathy, how does that affect you? What does that do as far as how it changes your corrective exercise that you're doing with them? How do you work out safely with them? How can you use exercise to offset the progression of that disease? And are you enhancing the workout sufficiently with sensory stimulation? Now, big takeaway from the webinar and from this webinar is that I want you to understand and remember that most peripheral neuropathies are sensory. They're not motor. What that means is that they might not feel their feet, but they can strengthen the muscles of the feet. And we just went over muscle strength and the importance of muscle strength. So you want to make sure that you are addressing the intrinsic muscles, the extrinsic muscles, so that you are keeping the motor control and the balance and the stability from a muscle perspective, knowing and appreciating that they have a sensory deficit or a decrease in that sensory sensitivity. Now, if you do not train the motor in someone who has sensory neuropathy, what typically happens is they will start to get muscle weakness because they're not contracting it. They're not using the foot really. And then they start to get hammertoes. And then they start to get increased pressure to the ball of the foot. And then they start to get flat foot, and they start to get all the changes of everything I just literally had mentioned. And the biggest driver to that is that they're getting the sensory deficit, which causes a muscle weakness, and then they just fall into kind of the aging process of the foot, where you necessarily don't have to. If you build in focused strengthening of the foot and is built into your programming from your client from the get-go, they don't have to experience all of these age-related foot changes. Now, if you are looking to increase sensory input, these are some of my go-tos. You can release the feet, so the rad roller on top. If you do 5 minutes of trigger point release on the bottom of the foot, research has shown an immediate improvement in balance. So any of my fall reduction training, I try to incorporate plantar foot release, and then I do balance exercises. Another great modality is power plate. I know you have a relationship with power plate at FAI, so please do check them out. Whole body vibration. It's one of the nerves in the bottom of the feet that is sensitive to vibration. So it's a great way to keep the feet strong, the nerves strong. Remember, what you don't use, you lose. So definitely incorporate vibration with these clients. Vibration is also a great way to build bone density. So if you have someone who has muscle weakness and you're trying to do everything you can to avoid stress fractures and fracture risk in general, power plate should be one of your go-tos. And then, of course, Nabosa technology, textured insoles, textured mats. Texture is what one of the nerves in the bottom of the feet are sensitive to. So you want to think texture, vibration, trigger point release, and keeping the bottom of the feet sensitive and alive. If you're looking for any additional alternative treatment options for neuropathy, please do check out my book, Barefoot Strong. I have a whole chapter based on this. I see quite a few patients in my practice in New York City about neuropathy. And the way that I approach neuropathy, and the way that I hope you approach neuropathy, or you encourage your clients to approach neuropathy, is to not kind of not become victim. That's not the right word, but just accept what it is and say, I have neuropathy. Okay, therefore I have neuropathy, right? And it is what it is. I'm losing sensation in my feet, right? We don't want to think that way. A lot of neurologists, no offense to Western medicine, but a lot of neurologists will address neuropathy purely from a pain perspective. So if a client comes in and they have painful neuropathic symptoms, they will give medication, Lyrica or gabapentin, Neurontin, some people know it as. They'll give a medication that will mask the pain of the neuropathy for the client, but then they won't do anything to protect the nerves themselves. They won't do anything to try to increase nerve growth factor or to try to repair the nerve damage that's occurring, or the inflammation to the nerves, or the oxidative stress to the nerves that are occurring. That's where I try to come in for these patients and teach them about all these alternative options that they can use to hopefully reverse or slow or stop the progression of the neuropathy. Some of these, of course, the sensory input, whole body vibration, Naboso insoles. You want to bring a stimulus. Again, had said it. What you use, you don't lose. You want to keep that stimulus. Vitamins. I mentioned these vitamins in Barefoot Strong, which you can get on Amazon, is taking vitamins that are shown to increase nerve growth factor are an important role of any neuropathic patient or client's routine or regimen. Some of these are acetyl-L-carnitine, arlopoic acid, L-methylfolate, magnesium. Some other ones that I recommend are different amino acids, L-lysine, L-arginine, things that increase nitric oxide and vasodilation. So it just helps the circulation to the micronerves. Light therapy, so infrared, and amber light, so 2 different wavelengths of light therapy. There's now, you can get little red light LED therapy systems, let's say on the internet, that you can put near the feet. You do a dose every day. It's essentially the equivalent of if you were in like an infrared sauna, or you do laser therapy. I used to have a class 4 laser in one of our offices, and you could use that for nerve health and nerve circulation. And then CBD is something that I use with a lot of patients as well with neuropathy. Now, the last area that we're going to go into, and then I'm going to take any questions that you may have of as it relates to aging related feet changes, how it affects movement, how you can factor this into your programming. And then please ask any questions that you may have, so that I make sure that you have some solid takeaways from this 45 minutes that we have spent. Last area that we're going to see is skin changes, fat changes, and vascular changes. So skin changes, this is important to appreciate that as the client gets older, their skin is going to get thinner. The reason the skin is getting thinner has to go back to collagen, right? Collagen is what makes up your skin. It's what makes up your bones. It what makes up your connective tissue and your tendons. It makes up your teeth. So much is related to collagen and collagen health. So if your client has, let's say, diabetes, poor glucose control, they're going to have thinner skin than some of your other clients. Thin skin not only is susceptible to a break, which means you want to be careful of infections, of course. That's one of the most common diabetic foot concerns. But you also want to understand that it'll be sensitive. Thin skin is sensitive for your clients. So if they don't want to go barefoot, let's say, they're very specific of the shoes they wear and maybe some of the insoles that they have in their shoes, because their feet are just hypersensitive. You want to appreciate that is part of aging. Does it have to be? No, but we do want to respect that thinning skin can be sensitive. Now, something that is similar to thinning skin as far as how the client may see their feet are very sensitive is what's called fat pad atrophy. Fat pad atrophy occurs in the heel pad and then the ball of the foot. So those two parts, it depends on foot types. You actually see fat pad atrophy at a little bit higher prevalence in high arches and in those that either wore high heels a lot throughout their adulthood, and in runners. You could probably also see it in dancers as well. So depending on kind of their prior years, what shoes they wore, how active they were, and things like that, they may be experiencing fat pad atrophy. If you feel your client's feet, or you do different foot assessments that we teach those in our BTS certification, you will be able to tell when someone has fat pad atrophy. It's quite obvious when you get used to what it feels like. The equivalent of it is that it's like you're walking on your knuckles. So imagine if you were to do like knuckle push-ups, right? It's quite painful. That's literally what it feels like for these patients or for these clients, especially in the ball of the foot. So what you can do for these clients is there's what's called a metatarsal pad, a met pad. If you go onto Amazon, Google met pad, you'll see exactly what I mean. There's a felt met pad that you can put on the ball of the foot, and it helps to offload and take pressure off of the met heads. Something else that you can do is there are insoles that are made out of plastizote. Plastizote is kind of call it like memory foam. It's a foam that adapts to the shape of the foot or to whatever surface it's on, and it offloads and redistributes the pressure. So it's used a lot in diabetics. It's used a lot in orthopedic. Think of like the aging foot where they have these hot spots. They have hammertoes. They have pressure to the ball of the foot. They have fat pad atrophy. They have thinning feet. That's classically the type of presentation that you would go to plastizote insoles. Plastizote, you can buy them online. It's like a peachy colored material. You can buy them on Amazon, I'm sure. So fat pad atrophy, you want to appreciate that. If your client doesn't want to do any of those, you can always do fat injections to the foot. And I'm not kidding. So the last area here is impaired circulation. Now, impaired circulation, This could be that maybe they have narrowing of their blood vessels. So they have high cholesterol and kind of stenosis and different vascular disease. Maybe they have diabetes. You'll start to see different vascular changes to the foot. It could also present as their feet are constantly cold. So if you have a client that always has cold feet, that could definitely be a circulation issue, which is age related, maybe for that individual. And that's where they might say, I can't do barefoot training because my feet get too cold. I have to have my socks on when I exercise. It's an age related change that you have to appreciate. How could you make that kind of a reality for them or help them? One thing I will say with the Naboso insoles is that people say that when you use the Naboso insoles, because you're stimulating the nerves, that helps to stimulate the microcirculation. And people often say their feet feel warmer. So we've seen some good responses for those that often say they have cold feet when they use the Naboso insoles. This picture here, if you're curious, on the left, this is showing Raynaud's. Raynaud's is it's a microspasm. And you see it typically when people have autoimmune diseases. You'll have Raynaud's that kind of gets looped up in it. It's inflammation that causes a spasm in the capillaries in the furthest parts. So they'll have it in their fingers and in the toes. They're very sensitive to cold temperatures and temperature changes because cold creates a vasoconstriction, which creates that spasm. So you may see something like a Raynaud's, and then you just want to appreciate, again, the same thing, like I said, could you use the Naboso insoles? Could you use whole body vibration and power plate to improve the microcirculation? One thing that I will say is there's some great research around power plate, whole body vibration. You do 5 to 10 minutes of whole body vibration and you get an improvement in the microcirculation, an improvement in skin perfusion. You also get a decrease in vascular resistance. So you get all these positive changes. So I have a power plate in my office. It's one of my favorite tools next to Naboso as far as something that helps with, say we have our aging client, circulation. Helps with circulation in the way that I just said. Maybe they have starting to get a decreased sensitivity to the nerves in the feet. It stimulates them and optimizes those. The bone density, vibration builds bone density. So that's a great way to do it. Vibration creates isometric muscle contractions. So you're building muscle strength to try to build that splinting effect and to avoid sarcopenia and muscle changes that occur to the foot. The stronger the foot, you help to avoid osteoarthritis. I literally was able to address every issue in this PowerPoint because of using whole body vibration. So it is a really powerful tool. Please reach out to me if you have any questions on how I incorporate PowerPlate into my office. So as we give you a moment to think about any questions, if you want to learn more about EBFA's education, please head to ebfaglobal.com. We have both live and online courses. Our online courses, we're doing a special on those now, just so that everyone can optimize their time that they're spending home. And then we have a special offer, 40% off all of our insoles through April 30th, which is almost like a 2-for-1 deal. So I really encourage you to check those out and get the insoles now while you can. We're actually doing a rebrand, which is why we are celebrating that. And we are partnered with Functional Aging Institute with Naboso. So please check us out also on their website. And we are very appreciative for our relationship, both EBFAs with FAI and Nabosos with FAI. And then both EBFA and Naboso's relationship with all of you and how you are using this information to help your clients better their lives, enhance movement longevity, and ultimately the quality of life. So thank you very much for your time. I will answer any questions that you might have.
Well, thank you, Emily. Great content once again. You covered a lot. Man, you really were efficient. So good job on that.
I try to think of them as teases, and then we can elaborate out on any of those.
No, you answered everything we ever wanted to know. There's nothing more to learn, Emily. Sorry. All right, so I've got a number of questions that have been rolling in during your presentation. So I know we can't get to all of them, but I'll just kind of give you a few of them. We got a couple about PTTD and
Mm-hmm.
what types of exercises would be most appropriate. I mean, are you recommending short foot? What about heel raises? I mean, what other exercises do you recommend for that?
Absolutely. So I'm going to go. So PTDD, the way that you want to think of this is you actually grade it based off of how severe it is. So if you have someone who has post-tib tendon pain, they typically say, oh, I have pain right where the post-tib tendon inserts, which is right on the navicular bone or along the inside of the ankle. Or they might say, I have pain when I do a single heel raise. So if you have them do it and they say, oh, this is painful, and they point to the inside of their ankle or kind of along the arch, that may be on kind of the lower side of uh, PTDD. What you want to do is first they have to not be in pain for you to strengthen the area. So work with a podiatrist on how you can address it. But one of your go-tos is that ASO brace that I had shown you. So using that brace, it's actually a post-tib tendon brace. ASO, go to Amazon, do not get any other brace, but ASO. You can train a client, think balance exercises in an ASO if their post-tib is irritating them. So that would be one way. Let's say they had PTDD and pain in the post-tib tendon, and now it's resolved. You want to strengthen the post-tib tendon through short foot is one. There's an exercise that I show where you put a ball between the heel and then you do a calf raise. It's on my Instagram. It's on our YouTube. It's kind of like a next level of short foot. That would be one. You can do calf raises. And then I tell everyone to strengthen the glutes and strengthen the core. If you have a client who cannot do a single heel raise, so they're standing on one foot and you're saying lift and they're like, nothing's happening. Most likely they have a tear in that tendon. Again, you may want to work with a podiatrist or physical therapist related to this. But if someone has a tear within the post-tib tendon, it's a little bit more difficult to strengthen that tendon. I would honestly say to go to that ASO brace and then strengthen the feet, core, glute connection and address it that way. And they might also want to be in orthotics. That's one foot type or injury that I do push towards orthotics.
Okay, good. All right, what about the rocker shoes? Got several questions that came in about the use of those. You know, who do you use them for? Exactly how to use them? Because obviously, you're thinking about some of you know, your exercise sessions or exercise movement patterns, lunges, squats, that sort of thing. Or are you saying when would you use those rocker shoes?
Yep, great. So let's say you have a client who has arthritis in their big toe. Let's say their big toe just doesn't even move, right? And you're saying, well, I want to do lunges with them because that's great for balance and glutes and all that. That's where I would actually push them into a rocker shoe during exercises such as lunges. If they cannot flex that big toe when they walk, they're obviously not going to do it when they are exercising. So any exercise, even like push-ups, right? There's a lot of exercises that we do that require flexion of the big toe. And if they don't have it, your client is going to compensate through that. So you want to be very mindful of that. I do recommend that a lot of my patients use like a Hoka as an example. It's one of the go-tos that I use, a Hoka for when they exercise, when they're doing push-ups, when they're doing lunges. And what the rocker does is a rocker shoe has either a graphite or a plastic piece throughout the entire shoe. So you can't flex it, you can't twist it, you can't bend it in any way. It's totally rigid. And they're rocking through it almost like a rocking chair. It offloads forces that are going through those joints and allows proper mechanics. So someone who's walking with a rocker shoe gets proper heel strike into hip extension into push off. So if they actually do have a true arthritis to the ankle, the midfoot, or the great toe, you want to do all of your exercises in the rocker shoes. Sometimes people ask, does that make it weaker because you're not going through it, so you're not moving the joint? if someone has, like, let's say an 80% arthritis in the big toe, you don't want them moving that joint anyway. It's going to be really painful for them. So you're not making it worse by using rocker shoes. Of course, you can get them out of the rocker shoe and do static barefoot squats, static barefoot, you know, bicep curls and different things like that. So see how you could intelligently incorporate static flat foot exercises that are not in those shoes, but then the more dynamic stuff, you want to be in those shoes.
Okay. And then what about using your Noboso mats? Like, when exactly would you use them? Just for exercise sessions? And would it be like yoga type exercise, or is this something they could use even at home to just stand on?
Yep. So all of the above. So you can use the Noboso mats either in your clients' homes, because they will help them to connect to their feet. So we've actually been doing several pilot studies in assisted living homes, long-term care, kind of that transition period where you might have an individual that's a higher fall risk or has decreased sensation for the feet, and you're really trying to mitigate that first fall or that risk of fall. Could totally be in the home. We have a 2 foot by 2 foot mat that a lot of individuals have in their kitchen, in their bathroom. You could use it, you know, in the hallway or for really any exercise then. So you're thinking not just yoga and Pilates. I know it looks like a yoga mat, but I want you to think more that it's a surface. We actually have a Noboso mat for power plate, where you could combine Noboso stimulation texture, power plate stimulus vibration together at the same time. So think, if my client's doing squats, let me do it on a Noboso mat. My client is doing bicep curls, let me do it. My client's doing balance exercises, boom, go to the Noboso mat. Or if you don't want to use the mat and they have their shoes on, that's where you would have the insoles in their shoes, and then do all of the regular exercises that you would do, knowing that they're getting this sensory input through their feet.
Okay, good. And so last question, we've got a ton of questions that have come in, but last question, because I think this applies broadly to a lot of people, and that is, when you talk about some of the preventive exercise strategies to reduce these changes that are occurring with aging, what are some things that you could incorporate into large group exercise settings? You know, when you've got, you know, more than just a handful of people to work with individually, what are some large group strategies you would recommend?
Yeah, so from a large group perspective, if you can do, you know, incorporating the SMR, knowing that everyone's going to have collagen changes, but again, it's a large group. So how do you incorporate trigger point release and SMR, knowing that some people's knees hurt and their elbows and they can't get down, they can't back up. So almost modifying the SMR to a group setting that could be done almost seated, in a sense that they don't have to get down onto the floor. Mm-hmm. Can you then start potentially, I mean, we'll just call this a chair class if you want, that everyone has their shoes off and they're doing a rolling to the bottom of the foot. Then they either have a Noboso mat or the insoles in their shoes, and they're incorporating the balance exercises in that. Appreciating that you're going to have people that have great toe arthritis and ankle arthritis. So maybe avoiding exercises that are high flexion of the front of the foot and of the ankle. You know, instead of doing lunges, favor squats, because the chance of you know, stressing the ankle will be a little bit lower and you're not in that flexed position. In the neuropathy lecture that I did, I gave some balance benefits as far as stimulating the hands, stimulating the eyes and the vestibular system. So there's a great way that you can incorporate sensory input for those that might have balance issues. I mean, at the end of the day, really what we're dealing with is people who have, you know, balance issues, muscle weakness, and of course their eyesight and their hearing has changed, which feeds into balance issues. And then osteoporosis, which means you want to really address the fall risk. So that it kind of becomes that you're able to address some of the two biggest pain points, or really the biggest pain point is the functionality, reducing falls and movement longevity. which is built around sensory input, small muscle strength of the foot, making sure that the feet are talking to the center where your strongest muscles are, meaning your glutes, and that they are able to coordinate that through both sensory and motor input.
So if you're incorporating short foot into your large group exercise programs, uh, what would be kind of the signs and symptoms from your participants that they shouldn't do that? So obviously you're not individually evaluating everybody, but what are the things you can tell, your participants? We're going to do short foot, but if you experience this or this, you shouldn't do it.
There really aren't. I would say the only one that would be let's pull back on the short foot would be plantar fasciitis.
Okay.
So if you're feeling pain in the arch where the plantar fascia inserts all the way in the back of the heel, that would be the one condition that I would say, let's skip out on this today. And instead of you doing short foot, maybe we'll roll your foot on a lacrosse ball or something like that.
Okay, excellent. Yeah, that's great. Well, Emily, thank you once again for joining us. We appreciate you sharing your expertise with us. A lot of great information, and just encourage all of you that participate. You have a lot of questions, a lot of interest in that, these topics. So please make sure that you check out everything that Emily is doing with the Evidence-Based Fitness Academy. She has a lot of great information on there on her YouTube channel. So a lot of the questions that you guys were asking, I know she's going to have some great content for you to go look for. So definitely do that. And Emily, thank you. Appreciate it, and hope things are going to go well with you in New York.
Thank you so much. For any of those that did not get their questions answered, if you wanted to email me, my email is education@ebfafitness.com, or you can follow us on Instagram or Facebook and send me your questions as well. I want to make sure that everyone gets their questions answered.
All right. Thank you again. You guys take care.
Thank you.